Well, we're so thrilled to be here with everyone today to present on our topic of fostering corrective, family-centered experiences, which is ultimately a very therapeutic model of assessment for deaf, hard of hearing, deaf-blind youth. And this is our baby. We started this work together in the summer, August 2023. So we're thrilled to share what we've done so far.
Indeed, yes, we are. Okay, let's see, how do we advance the slide? There we go.
Okay, so I'll go ahead and just describe a little bit about myself, and then Dr. Ryan will do the same. So my name is Dr. Sarah Schoffstall, and I am a white, hearing, non-disabled pediatric psychologist, and I currently work at Dell Children's Medical Center, and I also work in the Hearing Center, which is an audiological ear, nose, throat clinic. And so I have a really kind of unique opportunity to work with families, with kiddos of so many varieties who come through a hospital for medical care. And I'm thrilled to be able to offer a supportive framework that might be a little less medical, given that I'm not that MD doctor, but I certainly want to work together with our colleagues who are providing medical care.
Hello there, my name is Claire Ryan, this is my name sign, and I am a white, deaf female. I entered the PhD program currently because of my own experiences as a deaf child growing up and attending medical environments and seeing the type of advice that my family received, recommendations, etc., and realizing, wow, lots of things are missing in that world. So I was really motivated to go in as well and become a psychologist to help people reframe their views of deaf individuals, what deaf people are, their types of experiences, and have a more positive family approach. So that's something that I work with. So I'm really excited to share this model of what we're doing currently with all of you.
We'll give just a minute to let folks take a look. So we have a few main areas we want to cover today. We want to give just a bit of a background in terms of the mental health landscape, which many of you may know quite well if you're working directly with children and families. We also want to spend some time reviewing concepts and principles that are associated with a more therapeutic model of assessment versus a more traditional model of mental health assessment. And then we'll really dive into it with what we've worked on to develop so far through a specific clinic called the Texas Child Study Center, which is an outpatient mental health clinic within that hospital that we mentioned, Dell Children's.
Do you mind holding that clicker for me? So first, I do want to give you an overall view of what we know about deaf youth when it comes to mental health. There are lots of studies right now that show that deaf and hard of hearing and deaf-blind youth experience a higher rate of mental health issues. So the estimate to be at least 50% more to have one or more mental health problems. So that's a large percentage. Also, specifically when it comes to internalizing disorders such as anxiety and fear, having those internal things that you cannot see, those rates typically are more than 0.5% of deaf youth have those internal issues. The externalizing disorders such as behavioral issues, impulsivity, restlessness, inability to follow instruction, around 30% larger. So if you compare those rates with the general hearing population who are non-disabled, it's quite a discrepancy there, quite larger. Lots of times the medical settings see those statistics and they think, oh, it's because the child is deaf. and that's the cause. So of course there are higher mental health issues, but this is not the case. We have more and more research now that is showing that it's not because they are deaf, it's because of other experiences that they have had in their life related to unique environment, not having accessibility, communication barriers, and that is more of the cause that impacts those higher rates of mental health issues. So we want to focus on those factors rather than them being deaf. Okay, so now I want to talk a little bit about the traditional mental health assessments and what those look like, and how we are able to identify how we can provide those mental health services to people. So our practice is from not specific deaf training programs, but these are the more traditional models that we've used. So we want to tell you what those typically look like. Typically, they focus on these symptoms. So what is the individual showing? And that's the information that is gathered. And then they are given broad measures of everything from, it can be anxiety, depression, behavioral issues, attention, et cetera. So they give these general measures, and then they look at which area is the most high. So for example, if anxiety is shown to be high, then they'll give more targeted assessments in that area of anxiety, what type, and they'll get more information. If it's general anxiety or if it's a separation anxiety disorder, they'll take a look in that specific higher level area. So typically, traditional models are not very in-depth assessments. They don't really identify the causation for mental health issues. It's more theoretical. And so even if they identify a cause, it won't really change the treatment. Typically, traditional mental health, when they find a diagnosis, that diagnosis helps inform the treatment approach. So really excited about this psychological analysis piece here. So there are some limiting factors in the traditional model. First of all, we're talking about two different views when it comes to psychological assessments. The first one is etic, E-T-I-C, that view, and that typically is the belief that it's a psychological issue, or it's a symptom, it's a disorder, similar to the language, culture, backgrounds across the board. Doesn't matter. It's a standard thing that everybody experiences regardless. So there's no variety, there's no, and again, the belief is that that's going to be look consistently the same across different cultures and environments. So the second one is emic, E-M-I-C, and this is a different view, a belief that it's experience. It's the psychological disorder is unique based on the individual's unique experiences. So as the individual in their culture, within their language setting, the belief is that you can't expect that particular person to look the same across different categories of people. So when we think about deaf, hard of hearing, deaf-blind youth, we currently know that their mental health symptoms appear oftentimes, and we need to take a look at what is that underlying cause. It could be language deprivation that contributes to that, and that they are now at higher risk for mental health disorders. We know about the impacts of not having access to a communication environment. One is called the dinner table syndrome. And this one has such an intense negative impact on the individual's mental health. So those are some significant factors in that experience that, again, is unique to deaf and hard of hearing individuals. And we cannot neglect that when it comes to treatment and symptoms, because it needs to be really looked at and understand the child as a holistic person. So this diagram shows you the comparison between the two different approaches that I mentioned. So on the left side, you see the etic approach, which again focuses on symptoms, using similar, consistent standard measurements for all types of people. They tend to follow the diagnostic criteria, figuring out how the symptoms match the DSM for those diagnoses. So, and then the EMIC on the right, users measures that are more unique to that specific population, developed specifically for those people. And again, it's looking more at their life experiences and also asking questions about their symptoms, what they look like, how that manifests for that individual person. When do those symptoms appear? That's really crucial when it comes to the EMIC approach. In what environments do those things happen? Are they at home? Are they in school? Is it an environment where there's sign language or not? So where do they exhibit these symptoms?
Okay, so a little bit more about our therapeutic assessment model. So as Dr. Ryan just beautifully explained, there's a very traditional framework that often comes from a clinical psychology lens of pathology or something that's wrong with the patient, something that it's their struggle versus a more social issue. This type of therapeutic assessment model, which actually here in Austin, there is a TA Institute or Therapeutic Assessment Institute, yay Austin, encourages the process to be very patient-centered and supportive to the patient, identifying what it is they want to know about themselves or their experience, and that patient can guide the referral question in a sense, or at least they have more of a say in what it is they want to learn about themselves. So it's a team approach and a collaborative partnership between the assessors, the patient, and their family. So we were thrilled to be able to bring this idea into a very medicalized space, which can feel a little different, I think, or non-traditional, if you will. Okay, so a little bit more background. As far as clinic history goes, you may have come across the news or you may have seen just driving by that Dell Medical School itself is fairly new, actually. So that is the big name where we are employed. We work specifically within the Department of Psychiatry Behavioral Sciences. And in 2016, Dell Medical School welcomed their very first group of students. So thinking about that history, it's pretty young. We're pretty youthful over at the Dell Medical School. However, the Dell Children's Medical Center, as a pediatric hospital, has been in existence since 2007. So that history goes back a little bit longer, not too far. But thinking about how quickly and rapidly the medical care landscape is changing, we are, I think, every day trying to catch up with our environment, our setting, our colleagues. What are we doing now? So we're thrilled to be able to learn from you all, take your feedback in on what you want as a community to implement it into a medical setting. And like I said, the triage clinic where Dr. Ryan and I have seen our patients is through that Texas Child Study Center clinic specifically. That was something that was established in summer 2023. So that whole idea of receiving referrals from within our hospital, from a medical colleague, or from a community partner, and then assessing and sending out or making recommendations, encouraging other connections for the family, that's something we've been developing just in the last year. So we're pretty young in our work, but we're very excited about it. Okay, we'll just take a look here and I will expand on what all of these acronyms mean. But this is a chart that shows where our referral sources have come from. So I'll give you just a minute. Okay, and please let me know if this is not clear. We'll brainstorm again. Okay, so like I mentioned, since summer 2023, we've had a total of 32 referrals for kiddos spanning birth to the 22 spectrum is ultimately the patient population we can see. And the vast majority of these referrals have come from an ear, nose, throat department. So that would be someone in an ENT environment. That could be an audiologist. That could be the physician, the ear, nose, throat physician, who might be a surgeon. And I speak more clearly here with the second line, which is actually audiology is another source of referrals. So those are also providers that have come from the medical setting. We've also received referrals from auditory verbal therapists or speech language pathologists. We've received referrals from the neurology department, nurse practitioners, NP, and then thinking about our community partners and referrals, we've seen several patients referred from their primary care provider. Their parent might have pursued care, or maybe a provider from their school setting recommended that they seek care. But the vast majority have come from within our medical setting. Okay, we'll take just another look here at the referral concerns that have been identified, at least at the time of referral, what it is that we received about the concern for the child, the patient. Sometimes we get pretty clear concern, like we've had patients who might have expressed suicidal ideation while they're with their physician, or there's been some sort of a serious school crisis event where the child made a statement to their counselor of a threat, harm to others or self. That definitely comes up, and so we take a very urgent response risk assessment approach in that kind of case. But we've also received referrals where it's not very clear what is the concern. And so we've received, for example, concerns about family stressors. Maybe there's something that the child is experiencing at home with a family change. We're not so sure, so we need to assess further. Social anxiety or withdrawal. The child might be described as having struggles with peers or not engaging with others, all the way ranging to externalizing or behavior struggles, struggles with attention, can't focus, adjustment to a new diagnosis, if this is something the child just received or just learned about from a medical perspective, and adjustment to that. We've also received referrals for concerns related to bullying, device wear, again, sort of a medical process of thinking about we want to support this child's access, but through their devices. We've had a couple of families describe their stressors related to fostering or adopting and navigating that system. Okay. Okay, so like I mentioned, we have received referrals for children who are birth or just a few months of age all the way up to, actually 19 was our oldest. About half or a little less than half of our referrals have been in that 5 to 10 age range. A little less than half have been age 11 to 19, and then just a few referrals for babies or infants where their parents are navigating adjustment to a diagnosis. Okay, so we collected a little bit of information on what percentage of our patients had families who were also deaf, hard of hearing, or deafblind, and what percentage of the patients came from families with predominantly or exclusively hearing family members. And you can see that we actually have a somewhat solid chunk, 23% of kiddos came from a family where there was a deaf or hard of hearing or deafblind family member. And that is actually, thinking about Austin, a fairly high percentage compared to what we might see nationally, where a majority of deaf or hard of hearing kiddos are born to hearing families. So, yeah, so I think that reflects our local area quite a bit. Okay, and we also collected some information on whether the child had opportunities for any kind of signed language or used sign language in their home. We did not have any kiddos who were using ProTactile, but one wanted to. One was very clear that that was on his radar. So we had about 30% of our families with any kind of sign language, just even signs, all the way to a parent is also using ASL, compared to about 69% of our patients were in spoken-only home settings or using a spoken language only. Okay, and we also collected some information on where our patients were throughout their days in an educational setting. The vast majority, as you can see, are in a mainstream educational environment. 64% of our patients were placed there. We had about 24% of our patients who were in a deaf school or a school for the blind. We had about 8% of our patients in a regional day school program. I know that's certainly a Texas thing, but there are districts that have those regional programs within. And then we had just one kiddo who was homeschooled. Okay, so just to reiterate, what do we mean when we say that we're taking a collaborative, family-centered approach to our assessment? Again, the idea that the assessment process itself can be therapeutic. And by that, we mean fostering change and growth, not just for the patient, but also for their families, so that we understand that the child coming in the door might have been described as struggling with something, but in working to assess and understand more about that child's experience and the family's experience, we can create an opportunity to reframe or change how it is we're viewing this problem. And that's ultimately what we mean by corrective experience. Often when kiddos come to the hospital, they think they're getting a shot, they think they're going for some kind of medical problem, and we explain we don't do shots, we don't do medicine, we're here to talk about what's going on and understand what's happening. And emphasis on family-centered, because we know that as pediatric psychologists, if we don't partner with those families and if we don't establish a true rapport and alliance with the families, we have very little chance of working effectively to support that child in a more meaningful way.
Okay, so this is a general list of what our process looks like for assessments. So typically, the very first thing after we get a referral is we will do a review of their medical records. So we'll take a look at their chart, see who they've already seen, physicians, if there's been a referral from an ENT, take a look at their language history, just to see what opportunities have already been provided. Have they been exposed to American Sign Language? So that type of information that we kind of get a full picture of what we know about this particular kid. So what the needs might be and how that information can fit in with the reason for why they were referred. So once we've reviewed the medical records, then we move forward, and our first meeting is with the family. So we typically get together with them for about 2 hours, and we have a conversation, again, to better understand the communication, the supports, take a look at what kind of helps are there. We typically will start with the mom and dad, parents, to see how that goes, and then we'll break them up, and I might meet with the kid one-on-one, again, get some more information. Sarah may meet with the family, parents, and again, get more information from them individually. Then we do give them a measurement to get some information from the child, again, seeing are they using ASL. Once that assessment is finished, then we'll reach out to the school or perhaps their medical doctor, other significant people in the child's life that can give us some more information on how the child is functioning. We usually have at least one more follow-up meeting with the parents and the child, sometimes more, depending on how complex the situation is and what's going on. So we'll meet one-on-one with the child again more to ask some questions about how they're feeling, without the parents there. And then we may also meet with the parents individually to get just a full picture so that, the child has that transparency. Oftentimes we'll meet them all together. And once we've gathered all of this information, then we do type that out in a draft report so that everything is there. We're trying not to be too technical as far as percentages and different types of figures, but again, trying to match up what is it they're actually looking for. So once our draft report is there, we'll meet again with the parents. This is typically via Zoom. We'll send them the draft report so that they can take a look at that and review it ahead of time. Again, this is done without the child present because we really, we want the parents to be able to talk about their concerns freely, and we know that the child being there does impact that child. If they see the parents talking about them in specific ways, it can have a negative impact on the child. So we meet with them separately. We also, again, we've got the feedback from the child in the report. We want the family to take a look at that, make sure that we have accurate information, and then we will share more with them later with you about what that looks like. But we do provide resources at that point, community resources. We try to hook them up with get the child connected to other deaf peers, deaf role models. We mentioned deaf camps, if appropriate, where they can learn ASL. Lots of our kids do not have that visual communication. Those who do sign, they may not be fluent signers, so we do include lots of resources when it comes to ASL. We try to get a pulse on the parents as far as their receptivity. Are they accepting of their child being deaf? And we want to make sure that that's done appropriately with the child there or not. So again, are they happy with the resources that we provided? Some people say we've been looking for this or that specifically, so we can, accommodate what their needs are and include that in the report as well. So after we met with the parents and family, we'll tweak that draft and come up with a final document. We'll meet with the child, sometimes with the parents present, but sometimes individually. And give them that feedback. So I really like to create what's called a social story. So this is using pictures, and it might be we have a character from their favorite type of thing, and so we'll maybe do some role play. Let's say that they're being bullied in school, which is a pretty common experience. And so we'll say, hey, there's this character that came to the hospital because they were being bullied, weren't sure what to expect, and they met Dr. Claire and Dr. Sarah, and we'll go through this whole thing and have some expanding questions, and then the child realizes, oh, okay, this is a learning opportunity for me, and maybe they'd been nervous before, and they can realize that, oh, okay, well, they don't know if the teacher's, like, for example, is going to call my name, or, do I have to rely on a friend who can hear, has the teacher called on my name, and that's anxiety causing. So that also, let's say their peer is absent that day, then that nervousness increases, and oh my goodness, may not hear that I'm being called on, and the embarrassment that can ensue with that. So we give kind of this storytelling so that the child understands that it's a whole child environment. And this way we can better understand their experience too. So that's a part of the assessment process. But once all of that is finished, then, we talk about, were the family's needs met? Again, meet with them, meet with the child periodically to provide further supports and resources. We do like to check in after a month to see how things are going. Were the recommendations helpful? Did they help to increase some accessibility, communication in those different environments? And we check in again to see if the child's doing better. Do we need to make some adjustments, maybe some more recommendations? And we do follow up with those parents and families to provide that ongoing support to them.
Okay, so like Dr. Ryan beautifully described, we have a lot of parts and moving pieces in these assessments, and our communication with each other is key to remember, right, what are we collecting? What do we need now? What are we doing? What step are we in? But there are a few essential parts that we have to have at all times in these assessments. And we can't emphasize enough how important it is to review the history of the child. And often there's medical information, which is wonderful to have, but there's things that we realize we don't know a lot about. We don't know the child's access to a visual language. We don't know what that history looks like. So that really informs our clinical interview. And typically it's a flexible but structured approach. There are certain domains of the child and family's life we need to know about, but if the family starts sharing something that's coming up for them, we go with what they're sharing. So we follow their lead as far as what's coming up. Another essential aspect of our work is the behavioral observations part. And that's something that I will always wish I had a co-evaluator, co-assessor with, because if I see something, did you see something? I think I saw that. I need to kind of cross-reference, but there's layers of observation that we make from how the child's responding and where they're looking, where they're getting their information, where they're checking, did they catch that, or where they need more access. Also the interactions between the parent and the child and what that looks like. So we rely on each other to really observe what's happening in a dynamic way. And then another essential aspect that it's truly strengthening our work to collaborate with other providers involved in the child's life. We can't have a well-rounded picture if we haven't communicated with anyone else, such as the school team or that medical provider. Okay. There's a lot on this slide, so I will give you just a minute. Okay, so like Dr. Ryan mentioned at the beginning, we do have the opportunity to use some broadband measures, which are really symptom focused. So these are tools that are developed, not necessarily developed with deaf or hard of hearing or deaf-blind kiddos in mind, but they look at severity of various symptoms. So a really classic example is the first one listed, the behavior assessment system for children. That's 173 or 65, I forget, questions for parents.
Yep, it's long.
Really long. That's why we need 2+ hours for these things. For the parent to respond to how often they see a certain behavior or how often they are concerned about a certain social emotional aspect of the child's life. And that will give us information about how significant something is. It could be that the parent says, this is not a concern, to this is at risk, or this is really clinically significant. So that helps guide our thinking about what this looks like in everyday terms for the child. How clinically severe is something as a symptom? But we also have the ability to use all these other tools and measures to look at things like anxiety, depression, executive functioning, trauma, OCD, psychotic or psychosis-related symptoms, social communication experiences, adaptive behavior, and others that we probably haven't even mentioned here. But we're really fortunate that at the hospital, we do have access to some of these tools and measures, and we're constantly thinking about what else should we be adding. And that's honestly the way it goes, because as a child comes through the door and now we see something that we haven't seen before, we have to think about how can we capture this? Is there a measure that might help us determine severity levels and if a child would meet criteria for something? We're always on the lookout for tools and measures. But again, not population specific. These are not meant for deaf, hard of hearing, deaf-blind kiddos, so we are always extremely cautious. How are we making sense of these results? We don't want to over-pathologize, and we also don't want to miss something. So it's very much a struggle of how do we create a clinically accurate picture of what's going on.
I agree.
Okay, but good news is And this is why I'm so thankful that Dr. Ryan joined in the summer, because she was able to get access to some of these tools. These are some more population-specific tools and measures that we've been able to utilize. These tools, and I'll give you a second to just read them over. As you can see, the tools here are focused on quality of life, areas of functioning, and we also found a listening fatigue scale, parent and child version, so the child gets to report on their degree of fatigue or how tired they are after certain situations or certain environments.
Yeah, I'm curious, have you all seen these specific measuring tools or assessments? Are they new for you? Not a lot of familiarity. Yeah, so all of these, most of these are fairly new. I would say the first CROB and then the final one, the fatigue assessments, are new within the last several years, actually. So we've been really on the hunt for those, and we're able to locate those. The YQOL DHH is about 11 years old. They have an English version. They also have an ASL and a PSE, Pigeon Signed English version. This was before everything was online and we had streaming and that type of thing. So there's a DVD that's in ASL. Now we have the English version, but hopefully we'll get the ASL version back again. The DVD is no longer available. So, but yeah. Fairly new.
And just as a promo, I believe the Vanderbilt is free. Yes, I think you can just get it online, no problem. The others might have to pay for.
Yeah. The YQOL, you can Google that, and it is free online. The very first one, the CROB, you have to request permission to access that one.
Okay, and then as we've emphasized, but we'll be really explicit, we do a lot of dynamic assessment, observational, and collecting information about that parent-child interaction. There's some really nice tools that are available that are helpful, not necessarily designed for deaf, hard of hearing, or deafblind kiddos, but something like the Parenting Stress Index does give us information on if that parent feels competent as a parent, if they feel they have support from their parenting partner, if they feel that their child's needs are overwhelming to them. And so it is something that you can use pretty adaptively, even if it doesn't have questions specifically to your deaf, hard of hearing child's needs. In general, though, it is a really interactive tool that we like to collect data on. We also have seen great examples of families working together in a family drawing task where each party draws their version of what the family looks like. And I wonder if Dr. Ryan wants to give an example of a family that one of the kiddos drew himself. Yeah, I remember that one.
Yes, I do. So there was a family, that only one deaf child, and then the rest were hearing, and the rest of the family, young child, and had drawn a picture, and his ears were huge, and drew hearing aids and everything very clearly on his figure. It was interesting, the family said, oh, we don't even really think about him being deaf, or we don't even think about, they didn't use the word deaf, hearing impaired. He didn't think about himself being deaf, but the family was like, oh, the hearing aids are just part of his ears and it's not a big deal. And, this was their view of him, that the kid, but he had drawn these huge ears, and the rest of the family's drawings didn't even have ears at all, not at all hearing aids or anything like that. So his view of himself and his family, you could see a lot of information from that drawing, and this kid was about 6 years old, so that was very telling.
Yes, we have a lot of qualitative examples. We can share stories from our assessments. Okay, and then the other
Absolutely.
task we've collected information on is something called a sentence completion task. This is definitely not always appropriate if kiddos are still developing written language skills or they are needing support, but we can make it happen in terms of providing the child what is called a STEM, and then they fill in the rest. So it might be something like, my mom is, and they go ahead and maybe they sign, or maybe they say it, or maybe they write it out if they are comfortable doing so. And this gets us a little bit of interactive information, sort of in real time, what comes to the child's mind first. That's really what it's used for, just to sort of see what they say, what they share us. We don't score this, we don't give this points, we just kind of use it qualitatively.
Yeah, and along those lines, it's interesting because some of those questions for the sentence builders is, I wish, fill in the blank, or my mom thinks that I, blank. So my friend thinks that I, blank. My teacher wishes that I could do, etc. So, wow, we get a lot of rich information from that as far as their perspectives on things. Are we good? Okay, thank you.
Okay, I think we are doing really, really well on time, so we'll just keep going. We might be done a little early. That could be good too. Okay, let's keep going. Yes, so as we alluded to, yes, we have many rich examples of what this was like for kiddos and what they shared.
Yes, and yeah, I do just want to mention here, so in the previous slide, the questions, and then the responses that they check off, it helps you to see and then allows us to ask more questions too, so they can respond. Like, for example, what is their experience? And that will really impact their response. So lots of the deaf, hard of hearing, deaf-blind kids will notice, especially those who are mainstreamed, have families who are hearing, haven't thought about certain things when it comes to access, understanding, not understanding. They're just not aware of it. So I've noticed that if you ask a general question, are you doing well? Do you understand? They'll just say, oh, yeah, sure. Mm-hmm. So we get that a lot. So I look back to growing up myself as a child, and I didn't have any captioning. I didn't realize that hearing people could actually understand what was being said on TV or in movies. I just didn't even realize it until I was probably 12 years old. I went to a movie theater with my mom and my best friend at the time. And the film, people were speaking, and I was just so restless because these people's mouths were moving. There was no expression or facial affect. And I was like, hey, what's the point of me even being here? I can't understand what's being said. And then my mom was like, they're having a good conversation. They're having an in-depth conversation. It's very emotional. And I thought, wait, you can understand what they're saying? And Mom's like, you can't? And it was then that I realized, oh my goodness, all these years, like, people could understand what was being said on TV or in film. I didn't even realize that. So I see lots of that with other deaf and hard of hearing, deaf-blind children. They don't realize what they're missing until you pull something up or, something like that. I mean, as a psychologist, sometimes I'll start that conversation, especially if kids are so conditioned to just say, oh, yeah, I'm good, everything's fine, I understand, I'm following. Wow. So I really try to provide a safe space for these kids and say, hey, you know what, sometimes you might struggle if you're not understanding, and you can ask for clarification. But sometimes what we get back is, oh, that's not important, it's fine. And then that doesn't make them feel good, right? That's a blow to their self-esteem. So we want to be able to reframe these things for these kids so that they can draw information and really have access and use those personal experiences. So these are some examples that we have from the measurement of the YOQL, for deaf, hard of hearing, that assessment that we showed you before, YQOL. So one is talking about being upset when somebody doesn't understand what they're saying. So for this one, it's really interesting. We had a young kid who was 6 years old, and he would just shut down when he was having a conversation with somebody who didn't understand what he was saying. This is with spoken language. And he would just shut down. He would avoid having conversations completely because of speaking and not being understood, having people respond to him negatively. So this was a really powerful one. And then the second one up here, I feel like my parents protect me too much because I'm deaf or hard of hearing. We had a teen who had checked this statement off, and so I asked this person, I'm like, why did you respond in this way? What have you noticed? And they talked about how their parents would say, oh, the world is dangerous, and, you're deaf people are taken advantage of, and you need to be really careful, and, so they were worried about going to college and what might happen there. Even though the parents had asked me, oh, you're deaf and you've been to college? Like, what was your experience? So after being asked that personally, I was like, okay, you know what? And I described what it was like to have ASL, to have a community. And I think that's the most important thing, is to know your resources, know how you can self-advocate. So the parents learned from me in that way. So yeah, asking more, having them expand on some of those questions, we gather so much important information that way. And then the third one, this last one, it's hard to participate in family conversations in large groups. This is very common that we see from lots of deaf people across the board. Oftentimes when they come to the clinic, they're very anxious, they're nervous, they may not show it, they've kind of repressed that symptom, but there's lots of anxiety about being in large group settings, and sometimes the parents will be like, what's wrong? I don't understand why you don't want to socialize with particular people, or why the child's avoidant and isn't more assertive to participate in a larger setting. And they don't think about the accessibility piece and how anxiety producing that can be, to try to understand stuff, not be able to follow conversations, having to guess, all that work. And so the patient was able to say, sometimes if I miss something, I'm worried that I'm going to make an embarrassing statement that's off point. And so the parents became more aware after that statement was made. And sometimes, the person can say, I don't know what's being said, and I would rather, like if it's a sports team or something, I want them to go first so that I can see what's being done, and then I'm more confident to follow their lead, for example. So yeah, lots of really rich information comes out of these particular questions in this process.
And I think the fact that Dr. Ryan was able to follow up with this kiddo in a more one-on-one, or actually we were two-on-one with this kiddo because she was a teen and parents were in a different setting at that time. So we could kind of probe a little further. Sometimes we needed to create that space if we recognized we didn't have enough of it. And just one detail I apologize, forgot to mention, on these types of questions, the individual will say how much they agree with this sentence. So they'll say, I think 0 to 10 maybe. 10 is yes, I feel my parents protect me too much, 10 out of 10, or maybe 1. So we get to see how much they feel these ways. Okay, next slide.
Okay, and then this one, I'm going to let you read this real quick. All right, so these are a couple of examples, these 3 from different patients that we've had. So again, this is the sentence completion examples and tasks, and we see really consistent themes that you can see here, these examples. So the one is as far as the noise level goes. A child who, says, if the noise level is too much, it's just so much work to try to keep and maintain focus. Not being able to hear, feeling lost in those loud settings. And then I think the last one's really cute. I think my classmate should blank, be more quiet, was a response. So yeah. And then kids will often say, after they're in a loud environment, then they go home and they're just completely drained. That exhaustion and fatigue is quite an issue for lots of youngsters. They get home, they need to take a nap, they're worn out, they need to rest, they need some quiet time to be in their room alone and maybe take off their aids, that type of thing. So that really is a very common thing that we see with patients. Your turn.
Okay, so the way we then offer feedback to families is heavily, heavily contextualized, meaning we take everything we've learned about the family's circumstances, the family's history, their cultural approach to their child, disability, deafness, blindness, all of these things, and we try and meet the family where they're at. We always take a strengths-based approach to say, here's the things we saw. This was incredible. Your kiddo did this and this and this, and we saw it. They shared this and this and this, and they said all these things, or they were sharing so much. So we try to really go there first to talk about what we saw, what we observed as a strength, as something that is to be acknowledged. We also acknowledge how vulnerable these families are to come in and share about their experiences. They may never have shared about this ever with anybody. And then they had a medical doctor say, we need you to go see a psychologist. That might not feel good for the families coming in the door. So we try to really embrace the fact that they participated, they even showed up. That's huge to acknowledge. And what we then do after that is really try to capture and describe what we've learned about the environments that this child is in every day of their life. So we emphasize how important understanding those environments is, as far as access, as far as fatigue, as far as demand, as far as expectation in the environment. We try to explain clearly how that might be impacting their child. I think this next slide this next bullet is a great one for Dr. Ryan to also comment on, and normalizing what this is like for our patients.
Yeah. Mm-hmm. Yeah, and also just talking about how this experience and in the anxiety in group settings, conversations, and the fatigue and all of that, lots of deaf, hard of hearing, deaf, blind children, again, experience this. And I'll say oftentimes, I'm the only deaf or hard of hearing child in the whole mainstream environment. Everybody knows who I am, knows that I have hearing aids, knows that I have an implant, et cetera. And to normalize it and just say, you know, you can go out and meet other deaf, hard of hearing kids and feel like, you know, I can have conversations with somebody who has had similar experiences to me. So we like to emphasize that people find their community, those who have shared experiences and shared identity. It's just super important.
And as we've talked about in the beginning of our presentation, a traditional model of assessment would land on a diagnosis if warranted. That might be a mental health diagnosis, like an anxiety disorder or depressive disorder, something that sounds very clinical and pathologized. In some cases, these things are important so that others know what the child is experiencing, not the why, but the what. And so sometimes, as warranted, we go ahead and provide that type of information as far as, yes, your child meets criteria, and we know things need to change. We would never just send the child back out, well, there you go, deal with this. No, we would say, this is a clinical, significant a label that we can give to describe what's happening, but not necessarily why. That's also the really important part that we explain to families. And certainly in our reports and then also in our feedbacks, we cover a lot already, as you can see, but we do try to offer ideas, strategies, thoughts about what could we do to support. Always starting with where they're at now in their strengths, the skills they have, what they're showing already. We build from there. We have to build from there. Maybe we are making adjustments in the environment. Maybe we are providing different tools or other opportunities for access. Maybe it's teaching. Maybe there's a learning curve that the child could learn, and who would be best to teach? Who could we connect this child to allow that learning to happen? And then I love that our bullet here about managing expectations, I think really ties pretty well into Kiva's approach of discussing what are the expectations you're holding? How could we manage that?
Yeah, and some of these resources that we share will include a list of just as many as possible, different opportunities such as summer camps, so that kids can meet other kids who are like themselves, things in Texas, other states as well. For example, one time we had a kid who was really fascinated with space, astronauts, NASA. So we looked around and we found a camp for deaf kids that was space related. So we were able to include that as a recommendation or resources. For older kids, EYF, which is at RIT, Exploring Your Future. So for kids who are interested in those types of things, we give resources to them as the kids age, different things that match their age, like EYF and different opportunities for those older kids. We have quite a lengthy list of resources. So still not enough, but we do have a lot. And this is you. Okay. All right, so presenting this new information to families, to hearing families particularly. And again, we are in a hospital setting, so lots of our referrals are from ENTs, audiologists, speech therapists. So you can imagine what kinds of information the parents have been exposed to so far when it comes to their child. Oftentimes are very medical perspective based. Oftentimes they don't even use the term deaf because it's deficit based, and so it's very much a cure or fix mentality when it comes to hearing loss. And so one of the challenges as a deaf individual myself is trying to meet with families and meet them where they are. We want them to be receptive of the information. We don't want to just throw lots of terms at them and make them defensive. So it's a challenge sometimes, again, to meet them where they are. We also want to be able to advocate for the deaf child because, again, we have research that shows what trauma and harm is being done when it comes to communication, and that has such an impact on the child's lifelong learning, their mental health, their future. So we need to balance out the family being receptive to what the information is, meeting them where they are, advocating for the child, and giving appropriate, accurate information so that we can support that child's physical and mental health. Yeah. Great. So how do we present this information to families and help them be more receiving of that? So the model is from a meeting the families where they are. There are 3 levels. I'll let you take a look at this. Okay, so therapeutic assessment model is basically the idea that the information that we get from those assessments, there are 3 levels. So the first level is information that the family is already aware of. So this is already part of their schema, something that they already know about their child, they already have particular information or comprehension about their child. So that's the first one. The second level is level 2. This is information that's maybe a little bit different from what they already know and from what they understand. So some overlapping with prior schema and then some new information that's coming at them. So we kind of try to blend those together. There's a bit of an overlap there. And then the third level is information that is completely different from what the family, there's no correlation with where they're coming from whatsoever. It's completely new information. And this is oftentimes information that the family is not ready for, they're not ready to accept. They feel like it's off point and it's often rejected. And this is oftentimes too where we see families who are not receptive to clinical support. They might feel like this is completely different, it's not in line with my child. So we start with level 1 information when addressing and presenting information to families. We talked about what we've noticed, symptoms, what they notice, what we see. Maybe the child's withdrawn, they're not engaged with social conversations. We'll mention that they shut down, for example. And then if they meet the criteria for a psychiatric diagnosis, we'll have that conversation, and oftentimes family will say yes. now there's a name for it, social anxiety, for example, or some disorder, major depressive disorder, for example. So we'll go through that with parents, and this is information that they can easily accept. We then move to level 2, and we talk about, help them have a better understanding of their child and that child's experience when it comes to these symptoms. And so we'll introduce new information that is unique to a deaf, hard of hearing child. For example, it might be a major depressive disorder, and if the child has experienced thoughts about not wanting to be alive anymore, for example, if they're having those thoughts in specific environments, we'll talk about that. Maybe they don't have access there. So we'll go through those types of stressors, anxiety that they're having, maybe difficulty or inclination to detach from people. And so we'll talk about what is causing those different depressive symptoms. And also look at those causes too. And maybe it's not having access to the environment. There was one child who said that other hearing kids would make comments about their hearing aids or implants and not being able to hear, was feeling insulted, and said that this made me feel like I don't belong. So that's a really powerful statement. So we bring this to the parents and we say, this is something that's happened. Again, we share the diagnosis with them, and we add those types of comments and information to help expand on the parents' understanding of their child. And then we will ask them what their thoughts are. Typically, it's a very difficult conversation. I like to do this one-on-one without the child being present. Typically, they cry. It's very emotional. Parents sometimes feel guilty as well. So, we want to talk about what this means. We want to say we want to help your child. If it's anxiety or depression, we need to address those underlying causes with them. So it means we want to connect them to other deaf peers, perhaps, where they can feel that sense of belonging. Or maybe we need to find a way to, I don't want to say you've got to learn ASL, but they have to have full access to language. And oftentimes that stressor is related to communication, and that's a big barrier. So needing to kind of look at the causation and help parents be more receptive to that with that conversation. Yeah.
And I will say that this is an art and not a science, that every family we meet, we figure it out. There's not any one way to have these conversations. That's why we rely so heavily on our own clinical judgment, but on what we see as possible windows in. And again, it's an art and not a science sometimes.
Yeah, okay. So for this one, there are some challenges when it comes to assessments. The first one, language deprivation is a big one. So when we see specific behaviors such as repetitive behaviors, or it might be concrete versus abstract thinking, child having, and sometimes it can be tough to see, is this an autism type of a situation or language deprivation? And so this can be really challenging to decipher. We want to make sure that we have an assessment that clearly measures so that we get the appropriate diagnosis. We don't have that when it comes to language deprivation yet. The DSM doesn't acknowledge that. Hopefully in the next one it will be included, but hopefully, I know, fingers crossed. So this can be a challenge to really kind of parse those out, and also gauging the parents' readiness and their ability to accept this information, keeping in mind what's best for their child, whether it be speech or if they're a mainstream student, or what do they need. Part of their experience really is what is causing this angst for these children. Third one, availability of services and educational options for children, especially if they're mainstreamed in an environment where they're the only child who's deaf and hard of hearing. Maybe it's their local school. And how can we help them self-advocate? That can be very difficult. Even with mental health therapists who are aware of issues related to deaf and hard of hearing experiences, whether they sign, there's so few out there that are fluent. We can't see all those kids out there, so this is a real challenge. I think the other big challenge is working in a hospital setting with a medical team. I know that, the system has a very different view of deaf kids, signing the deaf community. So that's another challenge that we face as far as how to navigate when we have this system that we're under, giving a different message than what is traditionally that medical view. Yeah, great. I think that's you. Is that me? I think that's you. Okay. So in my observations, again, nothing's like, we don't have the specific research yet, but in my experience and observations so far, I have noticed that there are so many common experiences that come up, and that is listening fatigue. Whether they have a hearing aid, an FM device, or having to adapt or whatever, this listening fatigue is so consistently what we see. Kids are saying, yes, I am tired. Very young children are aware of this. So that Vanderbilt assessment, the fatigue, gives us so much good information. Even a 6-year-old can say, yeah, I'm just worn out. And it's in simple language. They can say, I wish I could sleep more, for example. That gives us an indication of fatigue. So we do see this quite a bit. I think lots of these really are no surprise to any of you, but the deaf, hard of hearing, deaf, blind, those who are mainstream in those mainstream environments with hearing families, without sign language, really do internalize those struggles and those stressors. And so lots of yeses to those, saying I'm fine, saying everything's okay, but internally really struggling. And over time, their school, their families, those people will say, oh, they're doing well, they're getting good grades, they seem to have friends, everything's fine, my child's doing great, they can hear, they can talk. But really inside, the kid reports a completely different story, that inside, a child who completes this assessment, their score is just, I said, high rate of clinical needs, but when you look at the parents and their reports and their responses, it's very low. They say the child's doing fine. So we get very different responses. The child is struggling even though they appear, quote, to be doing well. And then the other observation is a challenge is that typically the parents, teachers, special educators, professionals in their child's life, audiologists, have a particular view about their listening device, their hearing aid, their implant. They've got that, so they must be fine. That's kind of all they need as far as meeting those the needs, and they're getting along just well. But this is a real challenge, trying to explain to people that it's not just a device, and that doesn't guarantee success. Another observation that I've noticed, oftentimes kids are less willing to say or less aware of having anxiety or depression. It can be harder to have them state things that refer to that or acknowledge. They might say, I'm angry. They may say, I'm annoyed. We might see frustration come up. They're willing to say those types of words.
Yes, I think to just emphasize what we mentioned here in the first point, that even kiddos 6, 7, I'm going to guess if we had a 5-year-old who we adapted the Vanderbilt for in an appropriate way for a 5-year-old, could probably start to tell us this information. And I think from a nervous system regulation perspective, if we have a small child who's already feeling so exhausted or drained, we need to know this. We need to know this because that could be a huge precursor to other things going on and a reflection of what child environment fit we're looking at. It might be a really stressful fit at the moment. So I would encourage y'all to, in your work with your kiddos, ask about fatigue and energy and what do they notice, and ask about sleep too, of course, but this was something that frankly was surprising to me. It shouldn't be surprising, but it was important to document that we had these reports consistently from our kiddos as young as 6. And I do think that Dr. Ryan's point here about how it can feel relieving to hear a medical professional say, yes, you have your system, you have your device, you're set, you're good to go, this should work. I think a parent wants to be relieved, understandably, wants to know, yes, we've met our child's needs, but it is a little bit incomplete, an incomplete picture as far as, is this effective? That's a different conversation. And this is something we've kind of touched on already. However, we are very clear in our reports that we will make clinical recommendations. We might make recommendations for educational supports. We do make recommendations for community access and resources for further exploration. And we do say to the families, these are yours to take. These are not things we're mandating that you do, but we strongly recommend, and based on all the evidence we have. So again, that emphasis on meeting the family where they are. It might take a few times to review these resources. Like, what do you think about this now? What are your thoughts now? Any different? Are you ready now? So we kind of revisit over time. But yes, these are categories of recommendations. There's a couple really nice tools and resources books out there. Far from the Tree is a book that many families have read, and we encourage families to check that one out too, because it's all about the experience of horizontal and vertical identity development when a parent might have one identity and their child's born with a different identity that can be supported more horizontally from others in the community, sort of adjacent to their child. And yes, always emphasizing the importance of connecting socially with others, peers and families who can share in that lived experience with the child. Okay, we covered a lot, but we welcome you to reach out or share your thoughts and ideas, because this is always something that can be improved. And like we said, it's really young, so it's sort of pediatric. We definitely need all your thoughts about how we can keep growing.
Yes, I agree. Absolutely. Great. Thank you.